Hello, I'm Norman Swan. Welcome to this programme on trauma. It's the call that most rural and remote GPs and nurses dread. The accident in a difficult location needing assessment, treatment and transport. How to respond effectively is what this programme is about. You'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Let me introduce our panel to you. Libby Bowell is the Education Manager for the Crana Plus First Line Emergency Care Programme in South Australia. Welcome, Libby.
Thanks, Norman.
Previously, Libby worked as a remote area nurse and also works for the Red Cross internationally in disaster response. About to go to PNG to look after people with cholera.
On Saturday.
Well, I can reassure you today that we won't be talking about cholera in Australia. We're talking about things more mundane. Min Lekong is a Senior Medical Education Officer with the Queensland section of the Royal Flying Doctor Service in Cairns. Welcome, Min.
Thank you.
Min has been working with the RFDS for 6 years, and prior to that he was in rural general practice for 5 years. Mark Elcock is the State Medical Director of Retrieval Services in Queensland. Welcome, Mark.
Amen.
Mark has provided the clinical leadership behind the establishment of Australia's first fully integrated adult paediatric, neonatal and high-risk obstetric clinical coordination and retrieval system. He speaks Scottish and I'll do simultaneous translation for you. Ken Harrison is an anaesthetist and retrieval specialist with CareFlight in New South Wales. He's worked in trauma and retrieval medicine for 15 years and has an active interest in education and research in trauma. Welcome, Ken.
Thank you.
Ken has extensive experience in international disasters. He was part of the AusAid response to the tsunami affecting Aceh and the Yogyakarta earthquake on the island of Java. So welcome to you all. But on the phone tonight is Sabina Knight, who is a remote area nurse, Associate Professor at the Centre for Remote Health in Alice. Welcome, Sabina.
Thank you.
And we'll bring you into the programme later. Welcome to you all. So, I mean, what do you think what are the sort of data here on injury and how it compares across rural and remote Australia?
Yeah, if the graphic injury deaths in Australia 2004-2005 illustrates that basically the more remote you are, the more likely you are to die from an injury, predominantly motor vehicle accidents. And you can see in this graphic here, on the right of the graph is the remote areas, and you can see that there's quite a high proportion of deaths related to injury, even in a very recent statistic. If you look at motor vehicle accident related deaths in the same period, the same pattern of the graph. So the more remote you are, the more likely you are to die of a motor vehicle accident. And specifically looking at Indigenous Australians, you could see it's a busy graph, but essentially the white bar on the far right shows Indigenous males. And you can see that the more remote you are as an Indigenous male, the more likely you are to die due to a road traffic accident. And so this is really quite a stark statistics that the more remote you are, the more likely you are, if you get injured, you're not going to do as well.
The reasons, Mark?
Oh, I mean, I think there's multiple reasons why this is so. I mean, you've also got to remember that this is part of the picture we're looking at with the deaths. You've got to remember that for every death from trauma, there's about 31 admissions, hospital admissions, and another 140 ED presentations related to trauma. So that's sort of tip of the iceberg. But in terms of rural and remote, you know, I think we try our best within systems to promote equity of access to all Australians to access the same level of care. But we all know, people who work rural and remote realise that what we can offer out there is not the same as if it happened in metropolitan Sydney or Brisbane. So, you know, the normal things of, motor vehicle accidents, motorbike, agricultural incidents, violence, alcohol-related injuries, the comorbidities that are existent in rural and remote, I think they all add to the distance and the rurality of it all.
Is that one of the reasons for the high rates amongst Indigenous people, you think?
That's a large part of it. It's got to do with the remoteness. It's also got to do with individual factors amongst Indigenous, as Mark was saying, comorbidities. The fact that there's a lot less compliance with things like seatbelt driving, driving safe cars, doing things like that.
And if you've had bowel surgery and you're on warfarin, that can't help
It
either.
doesn't help.
Libby, your perspective on the reasons? You've seen a lot of this.
Yeah, I agree with what's been said. You know, that there's often overcrowding in vehicles, there's no seat belts, they're unroadworthy cars sometimes, the comorbidities, the isolated roads and the distances just must impact on the mortality rate.
Is there much variation in systems and responses around the country, do you know?
Look, I think there is variation from state to state, but generally a majority of the states have moved towards a centralised coordination service where you have one point of access where the provider who needs to get help to a trauma patient can contact one point of service and start to activate a well-structured trauma system.
Sabina, what's your perspective on these really unacceptable statistics?
Well, in very remote Australia, the systems are regionally based, but they are nationally consistent. They're largely Royal Flying Doctor Service coordinated in that they task the planes, and each regional centre there are retrievalists to speak to activate the response. So there is a bit of variation in remote Australia. Once you activate that and get to your regional hospital or en route to the regional hospital, you then activate the statewide system that Ken was referring to. I think that the big difference in very remote Australia or remote is the distances. The very poor roads, they're unsealed, road conditions are harsh, poverty plays a big factor. People can afford less quality cars, there are more people in them, and people have to travel further for anything. So the exposure to risk of motor vehicle accidents is much, much higher.
Just because they're in the car and longer at higher speeds.
Indeed, and fatigue's a factor. So aside from poverty, we have quite high rates of motor vehicle accidents associated with people who work in remote areas, travelling to work, people who are on holidays, and fatigue and loss of concentration is a major issue.
It's probably a significant issue in relation to recruitment and retention, some of the fear that people have about dealing with this thing. Do you agree with that, Ken?
Absolutely. I think that the more education people can get, the better. And certainly there's two aspects to it. One is that you feel like as a doctor out there or as a nurse practitioner out there, as a nurse out there, you know who you can talk to. And the second thing is you need to be trained to do the things that you need to be able to do. So,
what are the essential skills that you need?
Look, I think in terms of triage, the essential skills are to, in particularly trauma, you need to be able to very quickly assess some factors that are going to help plan your whole initial management and then retrieval and transport. And they would be things such as, if we have the graphic about the initial call.
Well, we'll come to that in a minute, but I'm talking about personal skills.
Personal skills, okay. Well, I think in terms of personal skills, you need to be an excellent communicator. You need to be able to organise and lead a team that can be often an impromptu team, so putting together a bunch of strangers to manage an accident is a skill that is particularly useful in remote trauma. And I think communication, leading a team, leadership, allocating roles, there's critical skills.
I think that if you're a city doctor heading out there, you need to make sure you've got the clinical skills that you need. You need to make sure and there are resources available that we're going to talk to, that you've actually got the clinical skills to be able to deal with the things you need to. And that's going to make you feel a lot happier that you know that if you have to put a chest drain in, why hasn't it been 15 years since you did it? Yeah.
Tell me about this education course you run.
Well, it actually came about through recognition by remote area nurses that, whilst the principles are the same for all emergency courses, that there's definite needs and definite gaps for remote practitioners. So in conjunction with CRANA, which was at that stage the Council of Remote Area Nurses, in conjunction with the College of Surgeons and the RFDS, they they extended the emergency course to include advanced skills and take into context remote practitioners and the fact that you work in an isolated setting and that you might need to step up to this to intervene at a fairly high level and do a skill level that might usually happen in a hospital.
So how do you get the course? Is it online or?
It's a practical course. It's 2.5 days, but it's now backed up with online ongoing education. But you can go to the Crana website, Crana Plus website, and enrol that way.
Mark, what are the features of an effective service, retrieval service?
I think irrespective of where you are in Australia or probably internationally, there are a number of fundamental requirements. I mean, you really require that designated single point of contact for referral communications and pathways to go through, irrespective of if it's sick or injury. You need that one place to go through. And I think you have to have a level of medical control and oversight providing expert and timely advice. And that you have to have the capacity to task and utilise the most appropriate vehicle, whether that's a road vehicle or a fixed wing or a rotary wing asset. And I think at the end of the day you have to have the available crew mix to send and retrieve these patients. So you have to have appropriately skilled and trained clinicians, whether a mixture of paramedics, nursing staff and clinicians. And
be prepared, Ken.
Yes. Yep. And be ready for what is going to happen before the patient gets sick. I'm hoping that one of the things that everybody takes out of tonight is that you think about what system you're in. Think about how your particular system works. Hopefully you already know the way that your particular system works, but if you're not sure, make sure you know how your system works, whom you can talk to, how that's going to work, and do it before the patient gets sick. Because if you wait till the patient gets sick, you're already behind the 8 ball.
And in terms of getting to know a town, if you're a new doctor in town, it would be one of the earliest things you should do.
Definitely. And also, if you're leaving and you've got locums coming in, make sure there is a system where they can get to know how to get help,
so what part they need to do.
Yes, it absolutely needs to be part of your induction. And trauma only works within a system. Even in New South Wales, there's no one hospital that can take care of everybody. Even the big ones in Sydney, no one hospital can take care of absolutely everybody.
And Sabina, anybody could be the first port of call.
Well, indeed, you will be the first port of call. In the small, rural and very remote areas, you're not only the first port of call, but you're the ambulance service as well. So there's issues that you need to consider about preparing to leave and go out to respond to a trauma that just don't factor into the other systems where you can send someone else.
Mm-hmm. Min, talk to me about the initial call.
The initial call, when you get contacted by a passerby or someone rings in and you know that, say, a motor vehicle accident has happened, a trauma, there are some key things that really are going to help you start to plan an effective response. On the graphic there, these are some of the elements that we would consider essential in the initial call. So, I mean, if I can just highlight a couple of them. Basically, the first thing that I would do is establish a clear line of communication, and that's mentioned in there. So you really don't want someone to hang up the phone and you don't really have an idea how to call them back. So you need to, very early on, need to know, how do I call this person back and how do I maintain an open line of communication? Now, that person might have come to you as a passerby, so at least they're there in front of you, but sometimes it's a call. The next big thing would be to know where the accident happened, because obviously that's very important. And then, some basic things after that, like number of people possibly injured, the type of injuries, and particularly some safety issues that might be involved. So it could be a fire risk.
So you're really gathering critical information from the person.
Yeah, you're trying to get as much information as you can. Yeah.
But it may not be a phone call, Libby.
No, it might be just somebody coming into the health centre. But I think there's also other points leading on from what Min said that really alarm me as a remote area nurse, rather than just like numbers. Getting a bit more of a story around the mechanism of injury. So if there's a rollover, or if they tell you that there's somebody deceased at the scene, then that's going to give me a really high index of suspicion that there's potentially some major injuries out there. Numbers don't always work. They'll, in Indigenous culture.
By numbers you mean what?
Numbers of
people of all.
involved. So I think you have to start to, like Ming said, gather your story before you actually get out to the scene and get as much information as you can.
Do we talk the same language when we are assessing people?
Hopefully. We should. There is only one language. EMST, which is ATLS for Australia, for those who've come from overseas, is the only language that is used in trauma. And the reason is it works.
So for people who don't know what you're talking about, tell them what it means.
Okay, ATLS is the Advanced Trauma Life Support set up by the American College of Surgeons in the late 1970s. It got brought into Australia in 1988, and in Australia it's called EMST, which is Emergency Management of Severe Trauma. It is a method of dealing with trauma in a systematic, stepwise fashion, which is accepted around the world as the only method of doing it. It's been translated into a TNCC and the Trauma Nursing Program, specifically for nurses, which is the same language, talked the same way. Great thing about it, you can be an anaesthetist, you can be a surgeon, you can be a GP, you can be a nurse. You all know what you're talking about. So in terms of managing trauma, absolutely it's the only way to go. And what it talks about is preparing first, which is what we're talking about, then triaging, then doing initial assessment, resuscitation, secondary survey, etc.
And assessment on the way.
Yeah.
And Libby, the on-site approach?
Well, again, it starts from the time that you leave your health centre, so letting somebody know, especially in the remote context, it's really important to raise the alarm, so either make that call to the RFDS before you leave the site to say, hey, I'm going out in this direction and this is the story that I've got so far. That may prevent the plane going somewhere else and staying on the ground and providing you with some support when you get out there. Alerting someone in the community before you go, seeing if you can get someone else to come with you, ideally a health worker or another nurse, but even someone else from the school or the police if they're there, that someone might be able to manage the scene for you so that you don't become another victim. From the slide here, there's some other points about thinking about from once the time that you're in the vehicle, actually starting to allocate tasks or roles with your teammate, working out who's got the most experience and who's going to triage, who's going to implement some treatment, who's going to...
That's if you've got a teammate.
That's if you've got a team. But in an ideal world, you'll at least go with one other person, and as soon as that happens, that's a team. Making the call, like I said, thinking about the safety of you once you arrive at the scene, so learning how to park the vehicle, having your doors open, having adequate light. If it's in the middle of the day, creating shade as soon as you can. And it comes back to what we've all been saying from the beginning, which is the more preparation you can do, and that includes the initial approach, then the next part of the intervention hopefully will flow from that.
Having the doors open.
Yeah, doors open, lights on, car parked on an angle, all things that you learn in a four-wheel drive course before as part of, and this goes back to even learning the primary, secondary survey and doing, emergency courses, the same deal. If you're going to be a remote practitioner, you need to learn to drive in those conditions.
Sabina, what are the skills required for triage?
Well, as Ken said, you need to be able to do a quick primary survey to identify those who are alive, those who are not, and then those who are alive, quick overview to see if they have an airway, if they're breathing, and there's simple interventions you can do as you go around. And I'm sure as we get to ABC that we'll talk about that in more detail, but you could do a chin lift to clear an airway. But really, the first principle of triage is to work out what you've got, and then what your resources are, and then how to proceed. In triage, as Libby said, in a remote site where you're going out, it absolutely contains you being safe first, so having that scene safe, making sure that dust controls, triangles, things are put out to prevent you being hit by oncoming traffic. There's not a constant stream of traffic usually, and so it's easy for someone to come up over the horizon around the bend and collect you, and it happens from time to time, and that's totally preventable.
Min, talk to me about ABCDE.
So ABCDEs is one of the principles of...
You assume that people know it, but let's just cover it.
Yeah, sure. So it's kind of a resuscitation principle, a mantra. And, you know, A is the airway, B is breathing, C is circulation, D is disability, and E is exposure and environmental. So it's just a very nice kind of, memory aid to systematically cover key points of resuscitation. Yep.
How important is the time factor, Ken?
Time factor is really important. And when you look at just one thing further about that ABCDE, when you look at the EMST manual, you'll see it's airway and cervical spine breathing and ventilation, circulation and hemorrhage control. I give you ABCDE by itself is what you do in a cardiac arrest. When you add on the rest of it, that's what makes it into a real trauma. You've all got EMST books, have a look at them. In terms of the time factor, yes, 20 years ago we used to talk about the golden hour, and there's been a couple of studies that have shown, well, there's nothing special about an hour, but there is absolutely no doubt that the time to definitive care is one of the factors in both reducing injuries, as Mark was saying, and in reducing deaths. And that's one of the factors why remote accidents and remote crashes and other remote trauma doesn't do so well because of the extended
But definitive care is a movable feast. I mean, what are you talking about when you say definitive care? That we're actually going to do a thoracotomy here, or what?
Yes, it's another thing to get into your mind when you're talking about remote care. Definitive care is where you're eventually going to end up. That might be in 2 separate institutions or 3 separate institutions to do 2 or 3 separate things. For instance, by the side of the road, Libby or Sabrina might be stopping some bleeding by putting a bandage on. It might be the official definitive care you need for that injury. If you happen to be in the Northern Territory, you might also need a laparotomy. That could be done at Darwin. But if at the same time you also have a spinal deficit, you're going to need eventually to leave Darwin to go down to Adelaide or somewhere. So defining definitive care is really difficult.
And it's what somebody needs at the moment.
It's what somebody needs at the minute.
Beyond what a layperson can give.
Yes, and it's also, and that's right. Yeah, that'll do for now.
Mark?
I mean, definitive care at that particular point in time might be, as Sabrina mentioned, just a jaw thrust chin lift. Mm. That may be all that's needed in somebody who's unconscious. All the way through to tertiary level care.
Which I think goes back to the point that we've all said earlier about having to, make sure that you're adequately trained if you're going out there, so that you do know those simple interventions in that ABCD part of the survey that does save lives and doesn't need a lot of equipment.
Yeah. Let's go to our first case study. There's been a car accident, approximately 25 kilometres by road from the closest Aboriginal community that has a health clinic. The incident is actually reported to that health clinic by the driver of another vehicle, and the report comes in probably about 40 minutes after it's occurred. The nearest airstrip is 2 kilometres from that community. All the roads are dirt, but they're in reasonable condition at the moment. The vehicle seems to have rolled and collided with a tree, according to the report, and the driver who reported it said it was on the passenger side of the vehicle. So when you get there, there are 5 casualties, all members of the community. The driver of the vehicle is outside the vehicle. He appears to be inebriated but uninjured, apart from some lacerations on his arms and face. A male passenger sitting on the ground next to the vehicle is complaining of chest pain, both front and back. When asked, he was not wearing a seatbelt. It's noticed that he's a bit lethargic and his breathing is rapid and shallow, and he's not willing to move very much. He's in a lot of pain. A young woman is found sitting outside the vehicle talking to the male passenger while cradling her baby. She's actually got a deep laceration on the left side of her forehead, is bleeding a lot, and when she turns to speak to you, she's turning her whole shoulders with her head. When you look at the baby, to your horror, you find the baby is dead. Another male passenger is found sitting in the car. He is responsive, but also appears lethargic. Libby, you're first on the scene.
Well, there's things that are a worry straight up. If there's just me and maybe one other person, then already my capacity is stretched with, I've got 5 injured people. There's 3 people that worry me straight up. There's the quiet person that's sitting in the car. Why is he still in the car?
He's the one who's going to die on you.
Possibly, or it may be just alcohol talking, but certainly he needs to be assessed. You've got somebody that's got rapid shortness of breath, that's got chest pain, that potentially has got an acute chest injury. They're sitting outside of the car. You've got a woman that's got a bleeder from a big scalp wound and potentially a cervical spine injury. You know that alcohol's involved, and you know you've got a dead baby. So you've got a really big event happening in front of you. So
I might bring in Sabina here. Sabina, how would you approach this after you've made that assessment as recounted by Libby?
So the first thing is to report in with what you've got very quickly, and then they're all, other than the baby, all people are talking, so we know they've got an airway. We've got breathing problems with one person identified. We've got risk of cervical spine injuries with all of them, and we've got risk of significant internal injuries with all of them. We have a deceased baby and other injuries that suggest the mechanism of injury was reasonably high speed. The patient that worries me most, that may deteriorate quickest, is the person who's breathing up. So we need to assess them for pneumothorax or a chest injury for which is reversible.
So when you examine this person, his breathing rate's up nearly at 40, his pulse is up at about 100 and feeling thready, feeling a bit clammy. If you're on the other end of the phone talking to Sabina, what's your advice here with this one, Ken?
This one certainly sounds like he has a significant chest injury, and what you're worried about is in that short time frame it's unlikely to be contusions, because they're the most common chest injury. That takes hours to develop. What you're worried about is either a hemothorax or a pneumothorax. 90-something% of pneumothoraces aren't tension pneumothoraces. There is the occasional one that is, and that's what you're really worried about with this patient. So the other number that I would like, if it's at all possible, is a saturation. Most people are carrying a little pulse oximeter with them. Can they put a pulse oximeter on and give me a saturation on him? What I'm really going to have a very low index of suspicion is suggesting that she have her kit ready to do a needle decompression of his chest. Not necessarily at the minute, because once she's committed to that patient, there are other ones she might need to go back to, but it all needs to be ready to go so that if she needs to do it, she's ready to go. And she also needs to have marked out where the second interspace is now. It's really easy to go in the wrong place in a hurry. So get a marker, find the second interspace on that sore side and mark it out now.
So you do it anteriorly?
Yes, yes. As a life-saving needle decompression for a tension pneumothorax in this remote setting, that's the way to go. Some of you might have heard people talking about doing open thoracostomies. And there is a place for that in urban trauma, where you're close to the major teaching hospital, where you're just doing something and 15 minutes later you're going to roll into a major trauma centre. That's not what we're talking about here.
No, we don't need the high drama.
No.
So what's going through your head, Sabina, about transport?
Before we put them on the plane.
Yeah, but the plane's 2 hours away in this case.
Yeah, that's right, so it doesn't happen here. We've got other patients to look after.
So tell me about transport then. You found out that clearly they're going to have to be transported. What are you going to do with them? And given that there's no ambulance in the area and the RFDS is 2 hours away?
No, well, you're the ambulance, so you've got someone on standby back in the clinic. Before you've left, you've told people where you're going, what you're doing. You've activated your resources to have someone behind. And what you then do is decide what you can do to stabilise quickly at the scene and take once you've stabilised, take the ferry people back to the clinic. It's a bit like, you're not so far away here, so it's a bit more like scoot and run principle. If you were much further away, you'd have to stay and stabilise the lot. You're worried about the person who's still sitting in the car, so you're going to make sure they've got oxygen, they've got cannulas in, and that somebody's watching them. And then either you transport them back or you stay, depending on the skill set of the team you've got with you, and begin the transport back to the clinic for better care in a more organised environment and where you've got more resources available to you. Good light, good air conditioning, This all depends a lot on whether it's day or night time, is it cold. As Ken said, if you want a pulse oximeter, then you don't want to be out there in the middle of winter and be relying on it with cold extremities.
What do you... I'm just going to read a comment from Alan Youssef from the Finlay Medical Practice in Victoria, who says, we're 300 kilometres away from Melbourne. If I happen to need a retrieval, it takes about 4 hours to get the team to come in. They come in and keep doing things for another 30 minutes, then it takes another 90 minutes to fly to Melbourne. Most of the time the patient could have gone by land long before air. We don't have a helipad, nearest airstrip is 15 minutes away. So I mean, what happens here if you're the most experienced person and just back at the health clinic there's just a bed? I mean, that's, you must ask yourself, what's the point of moving back to the clinic?
Well, indeed, that does happen. What has happened in the past is that you stay right where you are. You're only 20 k's away from the clinic, and you stay with your stabilised patients, or continue to stabilise, reassess and stabilise, and wait for the transport to come to you, and have someone in the community pick them up and bring them out to you. So you have to make that call depending on your resources and the severity of the situation.
So if this guy's really sick and you're got to stay at the scene, you'd keep the guy who's really sick with you at the scene and not transport him back to the clinic?
Yes, if there's only one of you. You know, you have to work. You might get the others who are, if you are convinced after assessing them and reassessing them that they're okay, or at least you're concerned about potential spinal injuries here, and so you're probably going to have to stay put and have the retrieval team come to you.
So the two, you know, Mark and Ken both, you know, squinted their eyes and shook their heads a little bit in response to that one. So you would actually go back to the clinic? Well, what's the story here?
The issue is you've got 4 patients at least you've got to move, and probably it might also be from a social caring for the whole community point of view. You in fact want to move the dead baby back to the clinic as well for a short period of time. But that's not, obviously that's further down the priority list. But with those 4 patients, patients are going to be here for a long period of time. It's very seldom in remote Australia you can have aircraft arrive to take 4 patients away now. So what's going through my mind is somehow in between the retrieval team that is coming, the person over the end of the phone who is hopefully giving good clinical advice, Sabina who is doing all the hard work by the side of the road, that you work out, are some of the patients going back to the clinic where somebody can do more of? Are some of them going direct to the airport, maybe one going direct to the airport for the first plane that's coming in? And are some of them sitting back here? And each one's going to have to be worked out differently depending on how the patients progress past that initial life-saving steps that they both mentioned. And I think what people have said there is really, really, really important. There are some initial life-saving things that can be done, that need to be done quickly running round. Okay, now you're talking about more stabilisation things. Taking care of everybody's cervical spine is not initially life-saving. Now you've settled, the dust has settled a bit, now you can get on and do those kind of things. And you also have to make a decision in conjunction with everybody as to what order are you moving the patients out to. And that could depend on what resources are coming. Are they coming from different places? If you're right in the middle of Australia and everything's going back to Alice Springs, well then they're all going back to Alice Springs. But if it was somewhere else, it might be that one aircraft is coming from point A and another aircraft is coming from point B, and it might be best to send them to 2 different places based on the resources available in the destinations they're going back to, etc. It all gets really complicated at this point and
Mark,
very difficult to make general statements about.
Mark, then Min?
I mean, for me, the fundamental principle here is, and Sabina mentioned it, you're recognising early that you have essentially a mass casualty incident. It wouldn't be in the middle of Sydney, but where you are just now with maybe 1 or 2 responders, your resources are overwhelmed. So you have to make some difficult decisions given the complexity of the cases and the resources you have. So depending on how far away help is, I agree with what you're saying. You have to make a call. Do I take all these people back? You're going to have to create a casualty clearing station or a holding place to look after people after your initial resuscitation. Is that the scene, or is that back at the clinic, or is it at the airport? And I think those are fluid things that you have to make a judgment
But you might
call.
have to leave the scene with the most critically injured person.
Yes,
absolutely.
Yes, you might.
You might do, and you have every remote ambulance will have a stretcher and a scoop. So you've got the ability potentially to take 2, because if you get help, you get another ute or another police vehicle. If it's a short hop, then you can begin a ferrying service. But you are going to have to work within your resources, communicating effectively and continuously with those in the community, those at your retrieval centre, the RFDS or whatever, and it may be the neighbouring community health service. It might only be 100 k's or 150 k's away, so they might be within an hour and a half to get you to provide help. So it will completely depend, time of day, location and distance from town. All of those things will come into the mix.
Mark, do you want to add something?
Well, I was just going to say, I think that initial decision as to do you go from scene to hospital or clinic, the important thing from my perspective is the mechanism, whether it's a ute, whether it's an old troopy, whether it doesn't matter, it's the level of care that's provided in that transit. So you can use whatever.
Well, and before you actually move out as well.
I mean, you'd want to do you look after your airway, you want to start some fluid, you want to start the real basic stuff there and then go. You don't want to be stuck in the back of a ute, bumping down the road, having to do life-saving manoeuvres.
Min?
Yeah, look, I have to say, I kind of agree with Sabina that there's certainly times in remote trauma where, because you don't have enough resources, you do have to spend a period of time at the scene. And I mean, in the city, everyone would think we just pick everyone up, send 20 ambulances and we'll just take them all. And you obviously can't do that in remote practice. So it's true, like Sabina says, sometimes you have to stay there and wait for more resources to come and get you. You do your best. You try to stabilise people as best as you can. And it is like a mass casualty situation, because this will overwhelm a single doctor, single provider location. I think that I have seen a lot of resources and improvisation used in remote Australia where, private vehicles have been used as ambulances, utility vehicles and so forth, and people putting mattresses on the back of ute trays and all that kind of stuff and using that as improvised ambulance. It's not ideal, but that's something.
And if you have to put somebody in a ute, what are the rules?
Well, if you've got to do it, remember it's not covered, and you drive slowly. You don't want to roll the vehicle over because it's not covered. You want to protect the person from dust, wind and debris, and you want to protect yourself. So you want to make sure you sit low in the tray, up towards the cabin. I think these are just some practical issues because we don't have full ambulance services in remote Australia. So.
Yeah. I agree with everything that's been said, but the other big difficulty about being out at the roadside for too long is that communication just falls down. You're relying on a sat phone, or there's less and less radio contact now, and I agree with everything that everyone's been saying. You're trying to do the greatest good for the greatest amount, but the reality is you can't get a plane in the air until communication is really clear. And often that means getting back to the health centre to properly assess people, and to be able to make that call about exactly what you need.
I mean, the distance is a big thing. But that example of the person that gave you the question there, Norman, that would be a completely different scenario if you're 300 k's outside Melbourne. To the one we've got just now, because we all know that sometimes if a patient gets taken to the nearest hospital, sometimes they can stay there for hours before you can get them out to get them.
Yes.
And it's actually hard to get them kept on scene.
Yes.
If that's the best
you're limited in your resources, so you're only so much IV fluid, you've only got so much oxygen, so you have to balance all of that.
Comment here from Pete Fenton, Cape York Health Service District. As an RAN, I would prefer the vehicle to be called a retrieval vehicle, not an ambulance. The reality is the clinic should always be set up as the emergency primary centre between the trauma and the transport out to a major care centre. So it's retrieval.
Yes, I think that's a good point. I think that the whole way along you have to look about where are your points of refuge. Your first one's by the side of the road where you're giving basic care. The clinic in this case, as we've all said, is just another point of refuge, but it's got a lot more going for it than the side of the road. By the airstrip might be another point of refuge. And it might be that some of these patients, if you've got 5 patients, it might be that one of these 5 patients gets driven an awful long way to another bigger area that can deal with it, because just transporting 4 patients back to a clinic where poor Sabina's by itself is not really doing anything. One of them might be, say, stable enough. Best care for that patient, considering how long the aircraft are going to get there, is that they get moved to another clinic as a point of refuge till they're eventually evacuated out by air at some stage.
What documentation would you expect, Min?
Look, I think
particularly in this situation.
documentation, if we go to the graphic about retrieval documentation, I think it comes in from basic to as advanced as you want. But essentially, you want the key elements of handover of a patient, whether it be written or verbal, should be that the documentation and the handover should be standardised, should be systematic, so that the person has a good idea about what the situation that patient has come from, what treatment they've received, what their response to their treatment has been, and what is required in the next phase of their care along the trauma system.
It's a lot to ask of one person at a scene in a remote area with 5 casualties.
It is. That's a lot, and I think you know, if we can bring up that graphic, there's a great example of that. That we, you know, sometimes you don't have much time and you're just writing things on the back of a glove, and I think that that might seem very basic, but you know, that can be enough to give the next level of care the idea about what that phase of care that patient has moved through, that, you know, they've required this X, Y and Z. So I think it has to be systematic, the handover, because if you don't have a systematic handover, that's when you put patients at risk.
I mean, that was what I was going to say as well, that we know from all the work that's been done through quality and safety of patient care that one of the biggest pitfalls and risks is patient handover. And we're looking at somebody here who might have been looked after by a number of healthcare professionals through their journey from the side of the road to the tertiary bells and whistles, and you can't lose that information that was from the scene and the observations at the time. So there has to be a structured handover and also a structured way of documenting what has actually been done.
And this is something, we haven't sorted this out yet properly, because we have sorted it out in some parts of some states doing some bits, but it would be really useful to have the same form everywhere, and it would be really useful to have that form available in you know, at least...
Because you might be asked a year or two later for it.
You may well be asked a year or two later, and it's you know, if you're the first person on a scene, you may well end up in court. And you know, one useful thing to do later on that day or whenever, write down, draw a little mud map, write down everything you can about it, because the first you're going to know about it is when you're doing some other job or working somewhere else in 5-6 years' time and a subpoena arrives, and it's never much fun.
Sabina, last comment before we let you go?
Yeah, well, one of the things that we have got on our side, unfortunately, is a bit of time, because there is delayed transfer, and so unless you are unable to leave the patient, you can usually put together a pretty good summary of what's happened and what you've given, at least to hand over to the flight crew. Then what you've got time to do after they've gone is to sit down and write it out a bit more comprehensively and fax it through to the emergency department, so that the patient name, ID, comorbidities, that's all important background information that if they're from the community you will know, and to be able to flag with them so that and then ring up, tell people it's coming. Unfortunately, you do have to take those extra steps to capture the attention of the receiving people. They're busy, but so that they know it's all too easy for pieces of paper to get lost in the handover, which happens multiple times.
Sabina, thanks for joining us. That was Sabina Knight, one of Australia's pioneer remote area nurses, talking to us from Alice Springs. Once you get back to the community here, there are issues with the community, aren't there? Because you're going to have to move people out, and that's a really hot wire issue for many communities.
Yeah, well, you're taking them out of their environment where they feel comfortable. Usually, if there's a big incident in a community, then they're well known. People are, you know, they're usually family. They're often family of the Aboriginal health worker that you may be working with. You may need to send an escort with these people, so it's about finding the appropriate escort. And then you need to think about the impact that it has on the family that are sending their family member off to the city. The reality that they won't probably be able to visit them, and the reality that they're going to be away from the family for a period of time. But, you know, utilising the knowledge and the experience of the Aboriginal health worker is really important at that point.
Let's go to our next case study. 52-year-old farmer is found unconscious lying beside his quad bike. Apparently he's been out spraying weeds and the bike appears to have rolled down the embankment and thrown him off. He wasn't wearing his helmet. His wife initially contacted 000 using a mobile phone, and an ambulance has been dispatched. This is in a rural area rather than remote. It'll take about half an hour to reach him, and she's been put through to you, Ken. And she reports he's lying on his stomach and his breathing seems shallow.
This is unfortunately not an unusual situation, but it's one of the good things that has happened recently. Some states like Queensland have got these whiz-bang video links. At least we've now got phone links in New South Wales. But it is not uncommon that you get
Nothing
this.
like using sort of 19th century technology.
Yeah, it is. We invented the phone a century ago and we can finally use it. But it is extremely useful to be able to talk to people in these situations. And the way that I describe what you need to do with this woman is that, first of all, you usually need to calm them down a little bit because they've just had literally the shock of their life finding her husband critically ill. The next thing is you need to communicate to her so she becomes your hands and your eyes, and so she can do those life-saving things that we mentioned before. So you need to really slowly and carefully talk with her about what is happening. I would like to find out from her how unconscious he is. Go through simple steps like that. Has he got an airway? What's his pulse like? If she's not sure what a pulse is...
So she gets a rapid St John's ambulance course from you over the phone?
She gets a rapid course whilst keeping her calm so that she can do a few life-saving things that are really necessary. But it has been really, really useful quite often. And even if it isn't life-saving, it is really reassuring to them that something other than they're waiting for another half an hour for an ambulance to arrive and there's nobody out there. Quite often, if it's nothing as severe as this, if it's a musculoskeletal injury, just reinforcing the RICE principles and getting them started now just helps in getting people over it. Rest, ice, compression, elevate. So it's the basic principles of dealing with musculoskeletal injuries, whether it's a fracture or a sprained toenail.
Mohan Swaminathan from Queensland Injury Surveillance Unit asks for your comments on the need for ongoing, really in response to this case study, ongoing injury surveillance in rural and remote and regional areas to identify local specific injury problems in the community and thereby allowing the implementation of safety factors working in partnership with local community groups. For example, quad bike injuries such as this. Community action. You're all into saving lives, are you? You're not really interested in prevention, is that right?
No.
Poor old Mohan is on his own here. Sorry, Mohan.
I think you look at, working in retrieval services, there are certain places that one over the years picks up as having certain mechanisms of injuries. Yep. Tropical islands, golf buggies, farms, quad bikes, that sort of stuff.
Anyone who's around Sydney, motorbike riders and the Putty Road, great source of business. Great source of business.
Mm-hmm.
So the question here is, what role do the people who are involved in retrieval have as members of the community in prevention?
Huge role, and it needs to be, easily the best way to take care of trauma is to stop it happening. And the best example in Australia is pool fencing. Pool fencing in Australia was brought in by a bunch of dedicated paediatric trauma specialists.
Okay, so this is the quad bike guy.
Yep.
Mark, when the paramedics get there, what's their role?
In this sequence, I suppose you've had first aid provided by a member of the community, and then the first responders get there in terms of paramedics, and there would be an enhanced level of clinical skill, acumen and experience in terms of looking after that patient there. So they're going to assess them, treat them, and then again
So if he's still
feedback.
unconscious,
Yeah.
how are you going to know whether he's got a spinal injury?
Well, I think anyone who's unconscious should be treating as a potential spinal injury. There are some hard clinical signs that you might see, but I think if they're unconscious, the paramedics and any other retrieval staff that you sent would treat them as an unstable spinal injury.
So if this is remote rather than rural, then you're doing it, you just assume that this is spinal.
You assume it's spinal if they're unconscious, that's right.
And is that what you do, Libby, in that situation?
Yeah, absolutely.
And what do you do, Min, when you're worried about the airway and you've got a reasonable index of suspicion that there might be a high spinal injury?
Look, that's a very difficult situation for the remote
That's why I
preventer.
asked the question.
Yes, I know. I think that you got a couple of options. Certainly simple airway manoeuvres can hold things at bay and maintain an airway, but for transport, generally
But you're not going to sort of slip his peg through his spinal cord by doing that?
No. That's right. So I think things like, simple manoeuvres like the jaw thrusts are helpful, but for transport, to get them to where they need to go, you need a secure airway. This behoves us as remote practitioners to make sure that we have skills and maintain skills in advanced airway management, things like intubation of trachea.
So is there a way to secure the airway without making them a quadriplegic?
Yeah, there is. There's certainly well-practiced methods to do that. Certainly EMST, the trauma course, teaches tracheal intubation with manual stabilisation of the head, so someone holding the neck whilst the other provider does tracheal intubation. That's one way. Then there's
Hardway's lying on his stomach.
Yep. You do need to position them with appropriate people so that you can do that procedure. But look, there's other ways. I think it really is a difficult thing for a remote provider. There are a couple of things we could say are useful. Certainly, the airway audits I've done in traumas, the laryngeal mask airway is a very appropriate and easy device to maintain skills, to learn, and there's good literature to back that up. And there's also can be quite a reasonable airway in trauma. If you have a high-risk procedure where you could, cause further C-spine injury.
So another question's come in, it's all very well, you guys, because you're doing it all the time, as a rural GP, you might only do this once a year or once every 18 months. And
I think that is really, really a very, very important question. But it is something. There are more things there are more education that is going out, but it is one area that we still need to lift our game on, and is one area that we really need to help rural GPs and rural other practitioners about.
So it's not just learning in the first place, it's maintaining the skills.
It's maintaining the skills. If you have somebody who comes in and one of the things that really worries these people is not just diagnosing it, but it's, okay, I've diagnosed that now I need to do an airway, or I've diagnosed now I need to do a chest drain. And the last one I did was 15 years ago. I think that Craner course for the remote area nurses is fantastic, and it is slowly going out. There is slowly more education coming out to where rural people work, and the more agitation that can be done to get more out there, great, because there's these skills that are really necessary that make people happier once they know that they are on top of those skills again.
So, what's your expectation when you arrive in your chopper or your fixed-wing plane? This sounds like the dream, this is what we've all been waiting for. Right. Manna from heaven, literally.
That's right.
Our problems are all over. Min has arrived.
Yeah. So, look, what we expect for transporting the severely traumatised patient to definitive care is, if I could sum up in one word, is that you should really think about preparing these patients as if you would for major surgery. Okay, so essentially, if you think about it,
so treatment occurs at sea level, or on the ground, I should say, not at 10,000 feet.
Yeah, well, no, there's a caveat to that, but essentially, before you put them on the aircraft, you want to stabilise them enough that their airway, their breathing, and the circulation, they're appropriately resuscitated. Now, there are specific things in the aeromedical environment, and I could categorise them to about 3 of them. And there's a graphic here about the aviation retrieval challenges. And specifically, in the aircraft, we don't have a lot of room to do things. So the more time you spend doing the things on the ground, so that when you put them in the, in the telephone box, and we can't do them in the things, when things go bad, we don't have a lot of room and a lot of space to move. Specifically, when you take them to altitude, they need more oxygen. So if they need oxygen on the ground, they're going to need more of it up in altitude. Gas expands. So any gas trapped in the body is going to expand, and particularly for trauma to the chest, we'd be worried about the trapped gas in the chest and the pleural cavity.
So you could turn into a tension pneumothorax.
Absolutely, and it's happened twice to me on retrievals where a simple pneumothorax has become a tension pneumothorax. Previously undetected, now has become a problem. So we have a low threshold to recommend pleural drainage before we take these people to altitude. The other big thing is that the aviation environment is a stressful environment. We shake people, we submit them to vibration, noise, and it can make them vomit. It can increase their pain. They're going to use up more oxygen because they'll be breathing faster. So getting people well analgesed is very important as part of transport preparation.
And sorry, can I just add to that, I think that the communication between the rural practitioner and the medical oversight, or the team that are coming to retrieve them, that is very important in that preparation phase, because there's a lot of time that can be saved by having, you know, simple things like IDC, you know, indwelling catheters, nasogastric tubes. A lot of those things can be done prior to you getting there, that are going to save you time to get them out.
Yeah. And that might help that poor GP who phoned up from, or sent a message from rural Victoria, you know, if the systems could be, you know, adjusted a little bit. Certainly one of the things we have found quite useful in New South Wales is just making sure that if we're sending a retrieval team out there, that if they are in a place where they can do things to the patient, everything is done by the time you get there. Yeah. Now sometimes that can't be done. Sometimes it's only the retrieval team that can do whatever is necessary. But if it can be done, and it is done, it saves time.
Comment from Buck Reid, the Ambulance Service of New South Wales, says it's important to note that ambulance services are integral parts of state trauma systems. The trauma system, including potential aeromedical response, is triggered from the 000 call. Is that true of all states?
No. No.
So it's not even true of New South Wales?
Oh no, it is true of New South Wales. Oh, absolutely.
Right.
Absolutely. And it is, and that phone call I was saying before, those ones that we get involved in, as a medical retrieval consultant for the ambulance service, that's how I get involved in those phone calls. But it's definitely not true of all states. And even within New South Wales, it's not really true of far western New South Wales. It's only really true of Dubbo East.
So in each area, you've got to know who you call.
You've got to know who you call, you've got to know what your system is.
Tell me about teamwork on the site, because this was where dangerous for you to tread. You arrive, you know, who leads, who defines the roles, who's going to be responsible, what happens?
Yeah, look, I think that's a great question. I think, you know, everyone expects in a major tertiary hospital a trauma team will manage a severely trauma patient. So you have surgeons, anaesthetists, specialists, you know, a whole teamwork. And in remote settings...
Until the surgeon arrives.
Until the surgeon arrives, and then it's just him, yeah, or her. And but in a rural setting...
Does he need help? He's all right.
In a rural setting, that can be really hard because, like you said, they might only experience a trauma once a year or twice a year. So how do you maintain those skills of a trauma team? Well, I think one, you've got to practice. Two, you've got to know the people that you're working with, and you've got to know the equipment.
But they're going to be strangers
available.
some of the time.
But that's the real challenge, is that putting a team together of a bunch of strangers requires leadership skills. So I think it's really important for providers out there, whether it be nurses, doctors, to practice and seek training and leadership skills about dealing with acute situations that are changing minute by minute. They're being able to put together a team and lead that team in an effective way. And I think that starts by defining team roles quite early. So we have a graphic here where there are actually several organisations. There's a Queensland Health nurse here, there's a Queensland police officer in this graphic, there's RFDS team. So you're having people from 3 organisations trying to work together as a team because they're out in the middle of nowhere. And they have to work as a team, otherwise you know, it's going to fall apart. So how do you define a team role early? Well, I think, you know, you do need to have a leader, and you do need to have someone who's going to say, you're going to do this, you're going to do this, this is going to happen in the next 5 minutes, after 10 minutes we're going to be at this point, and have an oversight of the whole thing. Because if you don't have that, then essentially people start doing things on different tangents.
I was just going to say, in the remote context, that might not always fall upon the doctor in the initial phase either. If they haven't got a lot of experience,
Totally
like
agree.
you're saying, and there's a remote area nurse there that's got a lot of clinical emergency experience, then it might be up to that person to put their hand up and say, hey, I am experienced in this. I'm happy to take the lead role until we get back to the clinic. So I think it's what you're saying.
You shouldn't let pride get in the way.
Yeah, it's about standing up.
Know what you can do and stand back and let the person who knows get on with it.
Certainly, I've been working in aeromedical retrieval for 20 years, and I'm never the one in charge at a scene. There's always with me a paramedic, and they've all had more experience than I've had at that scene control, getting along other agencies, doing things. They're always the one that takes that team leader role. My skills, when I go out there, are best looking at the sickest couple of patients, giving them good clinical care, and letting the paramedic who's with me be the one that does the overall team leadership. If not, a senior ambulance officer.
Mark, just quickly tell me about the role of support services here behind the scenes helping this process, people who are not on the scene.
Well, there's a crucial role there to support those initial responders and the rural facilities. And again, we spoke about systems earlier on. I think it's the basic premise here is early recognition and early notification to those support services. So again,
a good trauma service has defined those in advance.
Yes.
You know who it is.
Yep.
Yeah.
So in Queensland it might be Townsville Hospital or something like that you're talking to.
Yep. I mean, you have to know when you go to work somewhere what your system is. So that when you're stressed, you know the number to dial on the phone. And the person on the end of that, from a retrieval perspective certainly, should be providing you with clinical advice as to what's to happen there and then. The clinical advice is about preparation for transport, resuscitation, and also probably for the oversight of the retrieval teams as well. But you know, that support has to give you some good visible support to get on and do things, but at the same time organise stuff behind the scenes, and that involves clinical teams with the right skills to come out and retrieve that patient, and the aircraft the right platform to do it. And at the end of the day, you've got to sort out where they're going to go. So if you think they're going to require a neurosurgeon or an intensive care unit, we would be wanting to sort that out.
And you've got quite a sophisticated telehealth system for all this.
Well, over the last few years in Queensland, we've managed to get the funding to have about, I think we've got 83 or 84 sites at the last count that link into our central communication centre, the QEMS coordination centre, and that has allowed us over the years to really get involved there and then in the nitty-gritty of active resuscitation and trauma in the small hospitals. And it started off, we weren't really sure if it was going to work or not, if people were going to take it on board, but I think that the more people have used it, the more they've wanted it, and it allows that almost that equity of access to come in, and you can have a critical care specialist assisting those staff who maybe don't do that very often, helping them.
And is it improving outcomes?
Well, we've not actually done any studies to outcomes. It does. I think it does. There's a number of things it has done. We think anecdotally it's helped keep people in rural, remote areas because they've got that extra support for the really sick.
So they haven't, unnecessary transports are minimised?
Well, yes, I mean, we did one trial in Palm Island which showed that we reduced the retrievals by a quarter by using telehealth. But I think it's more than that. It's about, support for procedures, enhancing the triage, allowing us to make better informed triage decisions and resource allocation decisions, but it supports the rural practitioners on site.
Yep.
I mean, what do you do?
And it would be very difficult to do any kind of study to show a difference in patient care. That would be really, really difficult and really unethical to do.
It's the simple things that we find with the telehealth that make the big difference. It's those little things that people might not be able to get across to you on the telephone that have occurred or are occurring.
So, I mean, we've had a question from South Australia.
Yeah.
What if your patient's 190 kilos?
Yeah, well, actually, we just talked about this before we went on the broadcast. Look, I think that's a very challenging particular patient group. I think that our aircraft have limitations. I mean, every aircraft's got limitations. You can't do everything.
Including take off.
Exactly, take off, or even get them in the aircraft. I think in that situation you need to have, that's even more reason to have early contact with your organised trauma service and retrieval service so that we can try to plan...
Fly somewhere else.
Yeah, well, get a Hercules or get a bigger aircraft, but it's possible. It's definitely possible. We've moved much bigger people than that from remote areas. But
thank you all very much indeed. It's been a fascinating programme. I've reminded myself of some horrifying experiences in my early career, which I'd rather put away, but thank you very much indeed. What do you take home messages, Ken?
From my point of view, I think one big thing that hopefully people have taken away is to get to know their system, to make sure that wherever they're working, they know what works. And if your
before
system,
it happens.
Before anything happens. And if it doesn't seem up to scratch, then agitate to get it up to scratch. Because there are systems in every state that are available where you can make those early phone calls, you can get things sorted out. That, it's all part of health prevention. That's what we all need to be in, because it's the best way to manage trauma is to prevent it happening in the first place, and part of that is to get the system sorted out. It's the only way we make a difference in trauma.
Mark?
It's the same. I think you have to be prepared. You have to know before you go out there what your numbers are that you're going to phone a friend. And I think you have to get to know your team and know your environment when you get there.
Min?
Yeah, be prepared, be prepared, be prepared. Know your area, know your people, know your skills. Be prepared to maintain your skills because, you know, rural and remote trauma is not going to go away.
Libby?
Yeah, the same. Skill up before you go there. If you know that you're going to work in a remote setting, then skill yourself appropriately, and that should be from the doctor to the nurse to the Aboriginal health worker that's there. And what the boys said about knowing your team, knowing your equipment as soon as you arrive, just know the environment you're working in.
Yeah, it helps you to feel more secure and confident in the practice that you're doing. I hope you've got a lot out of this programme on trauma. Our thanks to the Department of Health and Ageing for making the programme possible, but thanks to you for taking the time to attend and contribute your thoughts and questions. If you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CPD points. And if you're a metropolitan GP and have been inspired by tonight's programme, please stay tuned for a short 5-minute video on the benefits and incentives of working in rural Australia through the Australian Government's Rural Health Workforce Strategy. Spark up your life. Go and live in rural Australia or even remote Australia. I'm Norman Swan. I'll see you next time.